Welcome everybody. I'd like to introduce Professor Paul Brocklehurst. So Paul has a very varied background, like a lot of us working are interested in epidemiology and trials. So he has a background in dentistry as a practicing clinician, and another degree in psychology, and he's a clinical research fellow also, which Masters in Dental Public Health as well, which has brought him to his current position in Bangor, where he's director of the clinical trials unit there and professor of health services research. And he's going to talk to us today on implementation as fore-thought trials and complexity. Thank you, Paul.
Thank you very much. So, yes, I've come across Ireland a couple of times, and you've always made me incredibly sort of welcome. So, I have a piece of flat sack there for energy, and I always go back about several stone, sort of like, well, several pounds heavier than when I arrived. I left this this morning, so this is Storm Doris. I got a phone call, this is from my wife. This apparently happened at 8:30. I was already up in the airport, but that's blocked off our road, that's our tree, and that's our house on the right-hand sort of side. So she's a bit frustrated with me at the moment for being here, having a lunch, meeting new people, and she's trying to sort out that mess. And there's about 5 sheep behind there, which are also trying to escape. So I'm not in her good books at the moment, but hopefully I'll be in your good books if I do a reasonable presentation. So who am I? So a bit about the talk. Hopefully I'm be talking for about 50 minutes, 45 minutes. Hopefully it won't be too rushed. If there's anything that's of interest that you're sort of seeing, because I think there's some things which we do and you probably don't do, and vice versa. So that's the sort of general sort of format in terms of the sort of talk. But in terms of who I am, introducing my sort of self. So we're a UK CRF-C registered trials unit. I'm the director of that sort of trials unit. It's called Enworth. I'm also Professor of Health Services Research at Bangor. Previously I was at Manchester University, where I did my consultant training in dental public health, and I still have an honorary consultant position with Salford Foundation for Trust, so I keep my hand in terms of dental public health. Background, as said earlier, is actually as a practicing sort of dentist, although I don't do that anymore. I'm also co-lead for health services research across the whole of Wales, so I link with the Deputy Chief Medical Officer when we talk about things, strategic things about how we develop the infrastructure to best generate health services research, not dental health services research, but more generally health services research across Wales. And for that, I also link in with the HSR in England as well, and that's quite helpful. You get some interesting feedback about the direction of health services research, and also where important sort of chief scientific officers and policymakers, etc., want to take things. So hopefully what I want to talk to you a bit about today is what I'm picking up, which is really about the importance of context in everything that we do, which is something that actually I think we kind of like ignore partly. And also I sit on the various different boards as well within the NIHR. So that's who I am. So where do I interest sort of lie? Mainly in sort of health services research with a dental sort of like flavour, although I've been doing some different sort of projects around sort of stroke and social participation, patient activation kind of work. So fairly sort of broad, but mostly in this area of health services research, which is where I'm coming from with this talk. So I'm not talking about precise interventions which can be well controlled. I'm talking about sort of dirty health services research and some of the challenges therein. Because I don't think we properly acknowledge that. I think we need to make that very transparent. So I'm interested in particularly, let's say, in complex contexts. Now, I'm not a statistician, okay? So although I do still like to ask the same kind of questions as statisticians ask, I always like this sort of slide. A slightly bit my principal statistician, but this idea about does it work? Well, it depends on does it and work, which is the kind of thing that she comes back to me all the time when I say, can we design a study in a particular way? So I'm interested in external validity, particularly, how we transfer findings from trials actually into clinical practice. So this is with my dental public health, some of my health services research and so on. I'm interested in actually what really happens when evidence goes into practice, and that's having interface. And this is a quote from a guy that published in Clinical Trials last year, and I think it captures, I think, some of the issues that we have with trials of complex interventions and those that are actually in complex organisational sort of settings. Because I think we often tend to overlook these issues, as I mentioned previously, about the sort of parameters that we sort of choose, how we then go about designing these sort of studies, and then how we interpret the results as if they're truth. And I tend to hold a sort of realist approach in terms of my philosophy. So I think there is a truth out there, and I think we need to make successive approach that truth. But I'm slightly at odds with heavily empiricist, positivist type of approaches, which might seem a slight juxtaposition given I'm a director of a clinical trials unit, which is all about that. But our main expertise is around complex interventions, so that's why I tend to sort of bring in my more mixed methods approach and my sort of slightly more fluid approach. So when I joined the clinical trials unit about 2.5 years ago, one of the things that I was very aware of was this noise about context being so important. And also we have an international reputation for implementation research. So people like Joe Malone, Chris Burton, they are key researchers in the field of implementation research. So I thought it would be quite an opportune time to build some of their work into the kind of work that we were doing, particularly around complex interventions. So that's kind of what I'm going to be presenting to you today, looking at the potential for implementation research in complex interventions and trials of complex interventions. Stress I'm at the very beginning of our journey, so at the end of the presentation I'll put some thoughts about where we think we are going in Bangor, and I've had a couple of conversations with different people, and it sounds like there might be some overlap with some thinking here as well. But that's where I'm very much at the beginning of my journey in implementation research. So in terms of the talk, I'm going to sketch out a bit, literally sort of sketch out, you'll see what I mean in a minute, multiple GIFs. Then I'm going to return to a few key issues around context, give you some sort of key references, and then look at possible methodological implications if we think those key issues are actually worth considering or important. So you all know this. Basically, try to adopt a positive approach to evaluation. So at its simplest, the idea is to create two identical systems into which a new component is introduced. Observations are made of outcome differences that occur between the experimental group and the control group. Obviously, we can have multiple experimental arms. And the other factors that could influence the outcomes as confounders are either taken account of a priori or post hoc through regression. Good internal validity, and then the effect is pooled and evidence-based policies are created. So we can represent that schematically like this, dividing the two groups, one experimental, one control, do the intervention, then measure the outcome, and then it's looking at the difference in that difference over a set period of time. This is the classic experimental sort of paradigm. So if we look at, say, sort of drug trials, I think this is quite an interesting comparison in terms of the sort of stuff that I look at when it comes to complex interventions. So one gets the drug, the other gets a placebo. A fairly simple mechanism in terms of that then transferring through the body, relatively speaking, to complex organisational sort of structures. And then we have this sort of relatively sort of straightforward pharmaceutical action. I hope you're impressed by these drawings, by the way. But the point here is that with sort of pharma interventions, relatively sort of speaking, so then we have this sort of effect, we measure that effect. But they're more predictable. So pharmaceutical pharma interventions are more predictable, they're more controllable. Commonly there's this sort of, obviously a sort of dose response, something about outputs and then measurement of those outputs. And the mode of delivery doesn't tend to impact on the effects of the intervention. Now then, if we think about, then contrast that, what about interventions in complex health systems? And I would argue that some of those assumptions tend to break down, and then it's a case of where's that breaking down and what kind of things can we look at in more detail. So interventions can be inconsistent in how they're delivered. They can be inconsistent in terms of how they're responded to. And anybody who's done any sort of work in this area will surely sort of see that this is the case. And also, more pragmatically, interventions can be inconsistent in terms of how they are measured. And I like to look at it in terms of this sort of like 2x2 contingency sort of table, where you have this sort of like potential for individual system differences in the response and the potential for consistency in the application or delivery of the intervention. And we often assume that we're kind of like in this area here, in a lot of what we do. Whereas actually, we rely on sort of randomization to split out the confounds as best as possible. If we can't do that, then we adjust for them. But what about this area here, which actually is the area that's much more common in complex interventions in big organisational systems? That's where I'm interested in. That's the kind of thing that keeps me thinking. So let's go back to sort of weight loss example, but this is a bit more of a health system approach. This is quite simplistic, but trying to sort of sketch out the point before we get on to few references. So I would argue that the complex interventions and the organisational sort of systems, more complex and complicated, they rely on multiple kind of mechanisms, often rely on different elements of those all coming together at the sort of same time to produce your effect. But this is where I think sometimes this sort of farmer model can break down a little bit, because I would argue that wherever we sort of start looking at psychosocial human mechanisms, you can get this sort of breakdown in how things are delivered and how things are responded to for very, very human kind of reasons. So it might be sort of like in terms of sort of relationships, it might be sort of structural barriers and enablers, things sometimes that we do take account of, like poverty, etc. But others that we don't normally look at in our types of analysis afterwards. And one I particularly like, my Donald Trump essay, is macro-meso factors. And actually for me, this is one of the most important areas that we actually don't tend to look at in very much sort of detail. But some of the structural incentives inherent in organisations actually, in many cases, can actually overplay the intervention itself. So my argument is that we commonly assume an intervention to be delivered, responded to, and measured as if we are robots, and instead of sort of thinking about how we best unpack this and look at it. And for me, this is where we come on to sort of like the benefit of implementation. I also think we tend to strip out, in many cases, the different contexts and mechanisms that can lead to the outcome measure. Obviously, we can sort of bring maybe a bit of a realist flavour there, where they make a specific case for looking at context and mechanisms. So this is the common thing, and this is, for me, a key area where we have this difference between actually the effect exercise that we see in the trial and then what we actually sort of see in practice. I think this is increasingly being recognised as a big issue. And how do we get around that? I would argue that what we need to do is think a bit more carefully about how we plan our trials and how we plan the feasibility and pilots of studies, how we do the process evaluations, which I'll be coming on to in a minute. So, okay. So for me, I think systems have a range of variability and stability in terms of mechanisms that make things work. A range of solutions are available to any given sort of problem. We might have an intervention that's actually we think is working, but there might be another range of mechanisms and solutions that address the same sort of problem, which we don't think about. Multiple mechanisms can operate. We often think about mechanisms in a singular form rather than multiple mechanisms. And in terms of the ability to influence these, again, as I mentioned in those previous sort of slides, it can be very different and there's different effects. So let's leave that sketch to one sort of side, but that's roughly what I'm kind of sort of saying. Okay. So let's just have a look and the reasons why. So as a director of clinical trials, I see a lot of applications that relate to complex interventions or interventions in complex structures that don't really take account of context or of confounders. And you have these clinicians who come in, bound in, they sort of got a fantastic idea, and they, a lot of cases, haven't even sort of talked to their patients. So for me, it's about sort of looking at, well, what kind of frameworks will be helpful in taking one step back and sort of saying, how do we better plan these kind of sort of trials? I would argue that if interventions or their delivery involve any kind of psychosocial sort of human element, or if psychosocial processes actually can modify the effect of the intervention, for me, implementation as a forethought is something that actually could be a helpful guiding principle. Often what we do is we have implementation as an afterthought. So we generate the evidence, and then we look at how we then get that evidence into practice. I would argue that was a possible line of research here, and actually sort of saying, well, let's look at this growing discipline, which is all about looking at the factors that influence the way that evidence gets implemented into practice at evidence generation sort of stage. So as we're developing the evidence, rather than actually once that evidence has been generated. So why is that? Well, again, I would argue that even with drugs that have a psychosocial, have a psychosocial element to their implementation. So now, this can possibly seem as a bit of a challenge to sort of an evidence-based, to the evidence-based movement. I don't think it is. I think it's actually arguing for a bit more sophistication in how we look at interventions in complex organisational structures. And it's not just me that is saying that. So this is Moore, and you all know about process evaluations alongside trials. This is a key seminal publication in BMJ, and he basically sort of makes a point I've been trying to make to you, which effect size do not provide policymakers with information on how an intervention might be replicated in their specific context, or whether trial outcomes will be reproduced. And for me, that's the key element. Are we actually going to be able to generate the effect that we see, what we're trying to do in the trial, actually in practice? So there was that seminal paper which led to the adoption of sort of an approach which used process evaluations alongside sort of trials. That, I think, is a good way of sort of starting point. We'll come on to a bit more about that a little bit later on. So that's why context is important. This is a very interesting publication. So this is a publication by the HS&DR, Health Services and Delivery Research. I would strongly suggest that if you're interested in this kind of work, write this down. So we have some very, very good authors here, including Joe Rycroft-Malone, the implementation specialist, Rosalind Rain, Pete Bauer, etc. And it's a book probably about, will take you a little while to sort of wade through, but it's quite a challenge to the classic empiricist positivist approach to interventions. It's basically saying we really need to move towards a much more sophisticated exploration of how we do trials in this kind of area, and that the traditional binary notion of effectiveness is a little bit sort of short-lived. And again, there's a lot of people who are beginning to sort of like come to the same conclusions. So Ray Pawson, I think this is helpful phrase. Interventions involve the actions of people, so are rarely linear and comprise a series of steps or processes that interact. We have this assumption that they don't necessarily interact often. A prone to modification exists in open and dynamic sort of social systems, organisational systems, that also change as a result of the learning process itself as well. So for me, interventions are complex and introduced into complex social systems. Let's think about Paul Glazew's pathway to this translational sort of pathway. Now, if you say you assume an 80% effect at each of these 7 stages in adoption of evidence, so this is awareness of the problem, then acceptance of the need to change, ensuring that it's applicable to the right group, ability to deliver the intervention, acted on by clinicians, agreed to by patients, and adhered to by patients. If we assume a 20% drop, so an 8% effectiveness is quite we're not seeing a huge amount of drop here, but the cumulative effect in terms of whether that intervention is actually adopted and maintained in the practice is quite low because of this drop across these different elements. Kind of like says the same thing that I've been sort of saying in a slightly sort of different way. Now, this is maybe slightly contentious. Hope there's no health psychologists in the room. If they are, I apologise. But I would argue that I think behaviour change is important. But I think the thing is that it's often assumed that if we get some evidence out, that if we can just adopt behaviour change techniques to the clinicians and to the patients, that will get the effect that we're after. Okay? And I would argue that actually behaviour change might include this one, operates much lower down at the later sort of stages of this translational sort of pathway. For me, context, if we can get an understanding of context, on the right-hand sort of side here, if we can understand some of this, then we might actually be able to hold that up higher as we pass through the translation sort of pipeline. So I would argue that behaviour change acts a bit later here, but what we're wanting to look at much more is the influence of context. This is where I think implementation has a lot to offer. So that's why context is important for me. And what we know from the implementation sort of literature in terms of evidence being adopted into practice, we know that robust evidence is not sufficient to facilitate diffusion. We also know the interpretation of scientific evidence is often socially constructed, and hierarchies of evidence perceived differently across different groups, different clinical groups. Tacit experiential knowledge, the kind of working day-to-day kind of knowledge, can often be privileged over and above the evidence, and evidence is debated and weighed alongside other factors. This is sort of standard implementation kind of factors which relate to how evidence gets translated into practice. Again, another one that might be of interest for you in terms of references. So this is Joe's work as part of an HSDR project, which actually looks at an organisational element in the NIHR family of structures, which is about bridging between evidence and practice. So these are the clerks. Have you heard of the clerks? So this is an organisational structure which is supposed to sit in that implementation sort of space and bring researchers and practitioners closer together. There's a lot of them, and they've been going for some time. And this was quite an interesting piece of work, because this actually looked at whether they were working or not. So if you're interested in this area, this is quite a good report. I'll refer to this a little bit later on. So it's actually taking a realist approach to seeing whether that structure actually sort of works or not. Okay. So again, another sort of claim to sort of suggest that context is important, this time in health research policy and systems. Sort of need to extract the core issues from the context in which they are embedded in order to better ensure that they are transferable across settings. So this idea that understanding that context helps us then to transfer it across the different types of clinical sort of settings. So I've said, I think context is important because of the fact that we have differing variability and stability in systems, a number of solutions to problems, as I mentioned before, range of mechanisms, differing ability of the individual to actually affect those mechanisms, and different relationships between mechanisms and outcomes. This idea of linearity and impact. For me, I would argue that this might sort of seem a bit sort of realist to people, but this idea actually of looking at both the context and the mechanisms that lead to the outcomes. And one of the things that we're doing quite a lot more these days in the trials that we're putting in, trial applications that we're putting in, is actually we're doing realist-informed process evaluations. So we're running process evaluations alongside trials which have adopted a realist approach. So we're actually specifically looking at context and mechanisms that might lead to those outcomes. So we'll come on to that a little bit later on. So for me, I think we need to sort of start looking much more carefully about the C and the M, and not just assume that the intervention itself leads to the outcome, which is the assumption that we often adopt in a straightforward empiricist positivist kind of approach. This, for me, this captures most of what I'm trying to sort of say in one simple picture. No matter how we design a study, design an intervention, etc., you can find that users will adopt that. And I'm sure that all of you who have tried to implement something in practice, some evidence and intervention in practice, you often find it's often quite different to how it's designed. And my point here is we should be looking at that. We should be accounting for this sort of pathway rather than pretending it doesn't actually exist, which it can be where some people are in terms of the sort of like accounting for this. So I think now we've reached the point where, in terms of articulating refined well, we can actually look at a better range of principles and methods to take to our trial design, or how we then monitor those trials once they're in process. Does that sound like a reasonable, or is that something which people are going, nah, that's rubbish? That's my kind of gambit to you and challenge, I guess. Now, I'm a mixed methods researcher, so I'm quite used to sort of like stepping into different camps. But for me, it's not what I'm sort of saying. There is an increasing understanding, MRC, NIHR kind of levels, that we need to do things differently. We're spending an awful lot of money on trials which don't produce evidence, we then don't see an impact in practice. And I think that's something which we need to sort of improve on. So if we can get one or two steps better, for me, that's an improvement. That's something that improves the cost effectiveness of what we do in terms of research waste as well. So these are my thoughts. So core outcome sets, I think, are really, really important. I think we need to sort of link policymakers and researchers earlier. So bring, if you like, content into the research process earlier. I think we need to consider theoretically informed feasibility pilot studies and process evaluations more than we probably do at the moment. We need to explore the potential implementation research and trial design, maybe even look at sort of realist and logic models alongside our classic systematic reviews. So I'm going to unpack those in the next sort of 15 minutes, and then hopefully we'll sort of finish with some questions and some challenges, no doubt. So the whole principle with core outcome sets, as I'm sure you all know, it's about making sure that when we have all these results stacked together, that they're using a common set of outcome measures that make that pooled effect size meaningful. Okay? And one of the things I think where they've made a real step forward, this is Paula Williamson's group in Liverpool, in addition to the trials unit, the trials research group up in Queens, etc. Where I think they've made a real step forward, and I was at the meeting in the Netherlands late last year, is in the involvement of patient and public involvement in that core outcome measurement development. Now, when COMET first started out, they weren't as heavy in terms of involving patients in those core outcome measures. Now that's changed, and I think that's changed for the better. And again, sort of Paula, well, this is systemic Kirkham, but Paula makes this point in this paper again about this whole issue about relevance. So there's a growing recognition that insufficient attention has been paid to outcome measures in clinical trials which need to be relevant to health service users, coming back to that Paul Glazier's idea, and other people making choices about healthcare, if the findings of the research are to influence practice and future research. So for me, patient public involvement is, if you like, one element of considering implementation across. So for me, implementation looks at the structural and contextual elements, but also patient public involvement. Coming back to Paul Glazier's idea, if it's not accepted by the patients, then you're going to sort of struggle. And this is the point that Paula makes in that paper in the slide before this one. So we've got to be having this discussion between clinicians and patients that come up with a common set of outcomes. Then you know, particularly if the patients are being involved and the clinicians are going to be delivering that intervention, you know then that when you get the effect size out through your meta-analysis, that actually has some meaning, that actually could impact on practice, because the people who have been involved and will utilise that intervention in that practice, whatever discipline we're talking about, it has some meaning to them. So for me, core outcome sets is a really sort of key element of how we go about taking forward an implementation type agenda. For me, sort of sits in that umbrella. So this is just looking at the dental sort of trials in Cochrane, so I'm a clinical editor for the Cochrane Oral Health Group, and you'll see it's much easier to do meta-analyses on studies where you've got specific pharmaceutical type interventions, coming back to that point I made right at the beginning of my talk. However, it is much more difficult if we look at that first line, when we're actually looking at these kind of complex interventions that involve multiple elements, multiple mechanisms, and are applied in multiple contexts. And we find it difficult often to sort of pull these together in any meaningful sort of meta-analysis. It ends up being a narrative review, which can be helpful, but still. So, linking policymakers, researchers, and the infrastructure better together. So one of my roles, as I mentioned earlier, is Health Services Research Co-Lead for Wales. And what I'm trying to do, and I've got a meeting in June to sort of kickstart this, is to bring the Chief Dental Officer, Chief Medical Officer, the Chief Nursing Officer, the Chief Medical Officers for the different medical directors for the trusts, etc., together in with health service researchers. So we can begin to get a dialogue in terms of how do we do this better. So formally, with an NIHR structural programme, the clerks, the collaboration for leadership and applied health research centres, sit in this area between practice and research. And that's something, if you to take away from today, in terms of, I don't think you have that sort of structure here. That's quite an interesting point. And they're doing some interesting stuff around trying to develop the research infrastructure. So what we're doing in Wales is trying to do something similar, because we don't actually have a clerk in Wales. We're trying to bring people together. So we actually occupy the same kind of like space, so that kind of policy decisions can help inform the direction of funding. And equally, research can actually have a proper impact on policy and practice, because they're being involved in how we set the agendas. So, theoretically informed feasibility and pilot studies. This is for me where the kind of implementation frameworks come in. So it helps us describe this: what, where, who, when, how, and why. So a paper which I would strongly recommend to you if you're interested in implementation is this Nilsson paper. Have any of you sort of seen this Nilsson paper? I find it sort of very, very useful. And what he does is he describes the different types of implementation work that's been done and the kind of like approaches to implementation. So he has a table which basically describes how implementation frameworks have been utilised. So that's a process model, that's determinate frameworks, sort of classic sort of theories, implementation theories, and evaluation frameworks. So it's very interesting for anybody who's new to implementation sort of science to actually have a look at this paper, because it summarises all the different available implementation models that are actually out there and shapes them into sort of domains. But one thing that he also does, which I think is very helpful for me as an interested sort of trialist, is he also, if you like, distills 7 of the most popular. And what he sort of says is basically, in these sort of like 7 implementation sort of frameworks, the overlapping set of domains across them all generally relate to characteristics of the users, characteristics of the context, and characteristics of the implementation strategy. And he lays these out, which we'll see in a moment. Because for me, if we sort of say that context is really important, and we've got actually a research area known as implementation research, which actually particularly looks in this area, post-evidence generation, why can't we perhaps use some of these domains and aspects in how we generate that evidence? So, we've got a discipline which actually looks at how this evidence is used in practice. So could some of those factors that are highlighted by the implementation researchers be helpful in how we're putting together when we do a feasibility study and a pilot study, or when we do a process evaluation? So could these be helpful in how we design? And we might not be able to specifically manage all of these, but it might be something that actually we can actually consider when we're utilising, when we're starting off on a feasibility study or a pilot study. So aspects of the users and adopters in your intervention. So some of those are like IMD, age, etc., gender, will fall in very nicely into that sort of personal characteristics. But other things like clinician's experience, attitudinal, cognitive behavioural barriers, healthcare professional and physician sort of barriers, looking in a bit more detail, putting a bit more structure on what we do in a sort of standard sort of process evaluation, helps us add more descriptors. So that's kind of characteristics of the users and adopters. What about the actual context? So again, in this sort of distilling of the sort of 7 implementation sort of frameworks, Milton comes out with these kind of key areas which are important in the adoption of the evidence. So could these be things actually important to consider when we actually are generating that evidence, at least to make a note of, to understand, to help with our planning when we're putting something together, or maybe at the feasibility and pilot sort of stage. And then characteristics of the implementation strategy, which might also help us think how we develop a trial. So the kind of support, the methods and strategies used, process, characteristics of the facilitation, change agents and boundary spanners, we'll come on to that in a moment, influences. So some things which we don't really sort of capture at all in how we sort of do our process evaluations at the moment, or how we might structure our feasibility study, kind of things that we might want to look at. And I would argue that implementation frameworks can offer an interesting avenue into this. Because we've got some guidance for more in terms of general sort of like domains, but for me, some of that is lacking somewhat in terms of detail. So my question is, could some of those things be helpful? Could some of the implementation frameworks give us additional descriptors and detail that might help us get more information about the context when we're running a trial? Like I mentioned before, we're doing a fair number of realistically-informed process evaluations. So in these realistically-informed process evaluations, we actually are specifically looking at what's the context, what are the mechanisms, are there multiple mechanisms which lead to the outcome, are there multiple outcomes, are they unintended outcomes? So at least we begin to at least think through those kind of things as we're sort of like following our trials through. And that as a framework has proved to be quite interesting and quite useful. And it again helps us just to wrestle a pure trialist kind of view of the world with something a bit more nuanced, more contextual, structural, taking account of structural elements. But we're quite poor at doing any of this, really. This is some work that we're going to present at the Society of Clinical Trials. And we're presenting all of this, going to be presenting this, we've had an invited session accepted at the Society of Clinical Trials to discuss the potential for implementation frameworks in trial design in Liverpool in May 2017. This is one of the papers I'll be presenting, or the posters I'll be presenting, just looking at dental trials which have some sort of psychosocial mechanism in the intervention, or psychosocial mechanism in terms of how people respond to that mechanism. And you can sort of see that, sort of in terms of basic things like theoretical frameworks, process evaluations, and patient-public involvement in the trials that I've looked at between 2010 and 2016. You know, the difference between trials and protocols of trials is quite staggering. At least it's showing an increase in the proportion of trials which have some kind of theoretical framework or have some form of process evaluation. But it's still not probably as high as it should be. So then we come on to things like boundary spanners and boundary objects. So these are the kind of things which basically describe the space between different elements. So if we look at the boundary object, this concept has emerged from studies examining the way different groups process multiple perspectives. And implementation researchers commonly look at boundary spanners, so those people that are key in making that intervention work in practice. Why don't we perhaps start looking at that in terms of how we put our trials together and how we do our process evaluations? Could this not be quite an important thing to think about when we're sort of running these complex interventions in complex organisations? So again, something else which might be helpful in the way that we're thinking in our trial design from an implementation perspective. It also helps us just sort of disentangle a little bit this idea of thinking about complex systems. That actually, you know, when we're doing these interventions, that the intervention and its measurement can actually be bidirectional. You know, the way that we measure something. And if we look at this, you know, what I can make Pavlov do as soon as I drill, he'll smile and write in his little book. Obviously, the story is that we know the other way around. Okay? But this idea that actually, in terms of intervention and its measurement, they're not necessarily isolated and singular. They can actually be quite, they can be bidirectional. And I think thinking about that implementation, that this is something which they fully understand. And they also acknowledge things like observer and learning effects. So for me, the idea of thinking about the potential of using implementation frameworks, the implementation sort of paradigm, actually helps me when I'm thinking about designing studies that are going to be applied in complex health systems. I don't think it's as relevant at all for sort of pharmaceutical types of interventions, but I think as soon as you have some psychosocial human element in it, I think it's for me, it's really important. Okay. And again, just another sort of point sort of saying we're still not quite there, even in things like behavioural change interventions, which are complex and consist of these multiple interactive components. In terms of things like fidelity, which is a key element, are people actually behaving as the trial was intended for them to behave? There's still actually, this is a very recent paper, only about 20% have actually really addressed receipt, which in this case is the first recipient-related condition that needs to be fulfilled for outcomes and intervention to be influenced as intended. So this idea that even in behaviour change types of interventions, we're still not even measuring some of the key things which I think we should be measuring in a lot of the studies that we do. So we've still got, I think, a long way to go. I'm going to last sort of like 5 or 6 sort of slides. This is from Eva Rayfus in Germany. She presented this at Cochrane. She was the headline sort of speaker. And this kind of like just talks about the same kind of thing, but from a systematic review perspective. So she talks about embedding the PICO question within a system. So talking again about the importance of context and its implementation, how we should actually describe the PICO question in this context and implementation sort of space. So what she argues for is potential use of logic model templates actually as part of the review process. So use of logic models, and she argues that it changes the way that the systematic review is actually conceived and conducted. So the system influences intervention effectiveness and systematic review sort of findings. So this sort of thing about one thing talking to another. And she would argue that the classic idea of evidence-based public health is to get your production synthesis, evidence dissemination, and its policy sort of making. And she argues for much more of a bi-directional relationship between policy making, PPI, etc., and the evidence production and synthesis, part of the point I'm trying to sort of make as well. So what are we doing at Bangor? So this is heads up really on some of the stuff that we're doing. So what we want to do is actually sort of review the literature to examine the common domains of all the implementation sort of frameworks. So sort of build on sort of Nilsson's work. Then identify the relevant domains from the current implementation theory and frameworks that could be relevant to trials of complex interventions. And then undertake a Delphi survey to gain consensus across trialists and implementation research community to come down to a set number of, sort of domains, which might be helpful in how we look either in the process evaluation sort of terms or in terms of development of feasibility and pilot sort of trials. So the output will be a theoretically informed framework, hopefully, for trialists to provide them with the domain-specific criteria that should be considered at the early sort of stages in order to generate implementable evidence. That's the kind of catchphrase really for what I'm trying to get at, is trying to improve the implementability of the evidence that we produce. And just last couple of sort of slides, this is an example of some of the work that Joe's doing, so this is a realist evaluation of the Clark sort of system, but you can sort of see when you take an implementation approach, the kind of factors and descriptors that you're considering. And I would argue these kind of things could be quite helpful in how we plan and design trials if we're going to sort of undertake them in complex social systems. So, as I say, very much at the beginning of the journey, happy to take questions. I'm just going to finish on this. So, the goal here is to replace sort of what we call random treatment. This is this quote from Lewis, which is what I call the way physicians usually choose treatments, with truly randomised treatment, such that such as that which occurs with a well-designed and implemented clinical trial. So we can truly learn what works best based on the experience of the patients that we treat. So that's well. Thank you very much for listening. So it's tend to obviously sort of push quite a lot of information out there. Some of it will probably be new to some people. It might not be new to other people, but quite happy to take sort of questions.
Thank you very much. That's good. What leaves? So I'm wondering, when you're designing a trial there for a complex intervention, you're looking at these implementation, trying to characterize, the context. What proportion? I mean, that's a whole layer above the standard work of a clinical trial.
Yeah.
So what proportion of it, how does that break down? Is that doubling the workload? And then if so, the funding, do you get funding for this? You submit a funding, this is a work package for the trial you submit, and what maybe the UK then is that very warmly received by the funders, that they expect this, or that they're certainly happy to fund it? Because when in Ireland, well, at least in my experience, we're nowhere close to.
So I'm coming at this from a position of the kind of, sort of people that come to me with kind of trial ideas, and how often in sort of complex organisational sort of structures, and how they're principally clinicians and they're coming to the trial unit for some systems. What I'm arguing for is that if we're going to be looking to try and generate implementable evidence, there could be something here which we could build into the existing structures that we have, but just to open our eyes to other potential areas that we might want to record and look at. So, for example, when we do our feasibility sort of study, rather than just coming up with ideas that we think in our own heads might actually be helpful in looking at, obviously the recruitment, retention, and fidelity sort of question, but looking at the intervention itself and how that might work. Developing something like this based on implementation frameworks might help us give a heads up during the evidence generation sort of stage, which can guide clinicians in terms of the things that they might want to look at. And that will change according to different sort of contexts. But at least we're having that thinking at that point. And I would argue that, so my background is dentistry. I come from Manchester. I think the last 3 trials that came out of Manchester showed no effect. No process evaluation. So we've spent probably 4.5 million on HCA trials, and we don't know anything. Other than that bit, the way it was done, doesn't actually work. So my argument here is that it's far more cost effective to actually be thinking about some of these things and building these things. It might be at a process evaluation sort of stage, but at least thinking about the kind of domains and descriptors that might be important, and they will vary according to the intervention, vary according to the context, but at least we're thinking about it. And I would argue that is much more efficient from a research waste perspective than it is getting all the way to generating evidence and then trying to do some behaviour change theory to actually get that evidence. If only we could get people to adopt that evidence. My argument is that could we not think a bit more, and I'm not sort of saying this replaces everything, I'm sort of saying could we not actually think a bit more about the kind of things that might influence implementation slightly earlier on, or at least have some descriptors that might be helpful to describe why something might be working, why it might not be working. Okay, so there's a potential lot of babies to throw out about bathwaters here, but I'm not arguing for that. I'm sort of saying actually let's keep the baby in the bathwater. But as Rosalind Rains argues in that HSDR report, I think we need to move to something a bit more sophisticated than the simple, does this work or not? So it's very much, I think, about either being more theoretically informed in that sort of feasibility pilot sort of stage, or thinking about more theoretically informed process evaluation.
And of the multiple things that you could examine regarding the context and the implementation, I mean, from what you're describing, you're going to focus on 1 or 2 specific, because there's no way you can capture the totality of the system, is there?
No, but I guess what I'm asking for, is it important to consider context at that sort of early sort of stage? Because the alternative to that argument is sort of say, well, we don't, or we don't think about it too much. We'll see what happens once that evidence gets produce. I would sort of say, well, I raise it as a question because I'm very much at this sort of early stage of asking this. But for me, thinking, given the kind of people that I sort of see, the kind of trials that I sort of see funded, and where I see the NIHR going, and their dissatisfaction with the amount of money that's sort of spent for trials which don't actually show anything, and then even if it shows an effect, the difficulty of making that work in practice, I think a consideration of context is at least worth thinking about.
You know of any Horizon 2020 grants where the context is so different in different countries? Has that also been adopted?
Absolutely. But I'm not sort of saying, I guess what I'm sort of saying is, would some sort of framework informed by implementation theory help us to at least lay onto an idea and sort of say, okay, which of these things would be considered to be important? The idea about the Delphi study and a consensus is part of that process. So you bring everybody together. Of course, interventions are all going to be very different, but I guess what I'm trying to sort of say is at least we should make that a bit more transparent. It's a bit like that sort of qualitative approach, you know, that sort of reflexivity sort of statement. You know, you say what you think. You know, they talk about sort of qualitative research being that and the sort of plural for anecdotes. I actually like qualitative research, but at least that tension about transparency is made explicit. What I'm sort of saying is a lot of times we don't make that so explicit, and I think we should. And then it's thinking, okay, what things are out there to actually help us to do that? If that makes any sense.
I'm a clinician with a very minor background in health services research and a long history of getting involved in pharma trials. And the very small amount of HSR I've done has been way more challenging and way more, I suppose, needing thought, you know, around the generation of implementable evidence, as you said. So my question is, you referred to the utility of Clark's, and you said that you didn't have one in Wales.
Yes.
So given that we're probably, I'd say 5 or 6 years behind the UK in terms of the thinking about implementation, and certainly in terms of HSR, would there be a utility for a Clark in UCC, and what are the barriers to implementing it?
So I would strongly recommend that report by HSDR. So this was a realist evaluation, so it picked up all the context and mechanisms for the different Clarks that they looked at. Clarks are quite heterogeneous in terms of how they function, where they're situated. Their goal is to do, they suffer from politics because depending who's actually funding it and who is actually, you know, is it the NHS, and then you've got more of an NHS sort of flavour, is it academic? But as an instance, as an organisational structure, things like Rotherham Reigns, for example, North Thames Clark, she's developing an academy as part of that, where she's training clinicians and nurses to become more research sort of savvy. So sort of like developing the understanding of what research is and what it's about. So that if you look at North Thames Clark, there's some interesting stuff there. Manchester's pretty good as well. They've got a few implementation researchers working there. I start off a very basic principle that I don't think you should. There's graduations to this, so I don't think you should be making all of the research that we do driven by policymakers. But I think policymakers may have some important things to sort of say in terms of how they understand their services, etc., which can help inform how we set research questions up in the first place. So what I'm doing in Wales, working with Deputy Chief Medical Officers, is bringing all these people together to actually start a conversation. Another place to look at, which has developed things very strongly, is in Canada. So they've got an innovation and infrastructure. And that is another place to look at CIFA. So that'll be another one to look at. For me, anything that we can do to try and bridge that so that we can become boundary spanners, so that we can bridge that gap between policy and research, practice and research, can only be helpful, in my view. That might be slightly naive, but I'm too long in the tooth now with sort of stuff that I do to actually sort of see that huge amount of separation actually is helpful in HSR. I think in organisational structure it's really helpful to have that input. So we're doing a contract evaluation in Northern Ireland, they're doing an NHS dental contract, so we're working very heavily with the policymakers to work with them. But I would look at North Thames, Clark particularly, I would look at that, Joe's report for HSDR. There'll be some good starting points. Okay, anything, I mean, what do you think about the general sort of direction of that argument?
Is there an evidence base of its benefit? Can you
I don't think we even started there. So yes, obviously, what you want to do at a meta level.
Because it assumes to me, which may be very different, that the policy maker knows. I mean, I understand that. I can see the logic perfectly. There's absolutely no point having research where you've standardized an intervention and clearly demonstrated in that standardized intervention you could reduce an outcome by 10%. And it turns out that standardization has no meaning, applicability across the health system. So why are you doing it in the first place? It would be much more sensible to have investigated an intervention of what actually happens. You have to standardize it to a certain extent. But the challenge in that is where you get enough people with a common ground that the person actually understands what determines outcomes on the clinical side, which certainly I don't have much confidence that any of our senior management levels, on the hospital system have. But then the extent to which you can accurately, predict the way in which it's going to play out.
Yeah. So implementation research is, as a science, it's fairly new, relatively sort of speaking. And what you probably want to do is, if you're sort of taking this as an experimental paradigm, is you probably sort of want to have a look at this, sort of developing something like this, and then test its effect. When I talk about policymakers, I'm talking about obviously one element of implementation as I sort of see it. I'm not sort of saying that we should bring policymakers and researchers together and everything will be rosy and lovely. I'm sort of saying that we need to think a bit more. That's an avenue in and one part of understanding the context. So for me, the big argument here is around about, I would argue that it's important to understand the context to then help to design the intervention. And that is one element of that. But it shouldn't be the only element of that. It helps to inform that process. Otherwise, on that Paul Glazer's sort of transitional pipeline, you do get into sort of issues. And I've seen lots of examples where guidelines have been produced and it's absolutely had no effect whatsoever.
So the process evaluation, before you design an intervention, it's sensible to do a process evaluation to understand the clinical context that ultimately that intervention might be applied.
Okay, so process evaluations are formally described by Moore to sit alongside a trial. Okay, so the trial's ongoing and you've run this process evaluation. So I think there's an opportunity there to to borrow from the implementation researchers in terms of the kind of domains that we might want to consider looking at as part of that process evaluation. We've done it with realists and that's worked quite well. So that's kind of one element. Then you can take one step back from that and you can think, okay, I've got an idea for a trial, but I want to go through the feasibility sort of stage or pilot sort of stage, depending how well worked that the intervention is. I'm arguing there that, again, you might find it helpful to have a range of descriptors, kind of things to look at when you're doing that feasibility study and pilot sort of study. So then at least when you then come into your definitive trial, you've got a better understanding of actually what could be influencing the effect of that outcome, what's producing that outcome, and what might be actually an important confounder that you've not even thought about. So when you think about confounders, we tend to go for age, gender, and IMD. How many have you seen where you've seen another confounder other than that? They're your three main confounders. I think in complex organisational settings, there's a number of confounders, and this is where I think the implementation just helps us to guide. I'm not sort of saying throwing anything out here, I'm just sort of saying could we augment what we currently do with something which is an area of research which focuses on how to get evidence into practice, but rather than doing it as an afterthought, looking at it as a forethought.
Would you have any expectation of actually adjusting outcomes in any way for some of the variability you might see in processes or context?
Well, I just think I come back to that very sort of first slide by Lewis. That assumption that we have as trialists. I think that the idea of qualitative sort of stuff is actually quite nice, because we do think we get this p-value and it's nice and we're comfortable with that. It all sits nicely with us as sort of statisticians, etc. But so often they're based on estimates, and the point I'm trying to make is that's fine, but we should really be getting behind that. Like I sort of say, these dental trials that I've seen in Manchester, very well done, but showed no effect. And then where do you then go as a policy maker? Why didn't you? So, in that particular example, we could have used implementation frameworks to help set up sort of process evaluation to understand the kind of key drivers for that no effect.
Paul, can I ask you, when we're getting together as a team or a PI, and everybody's interested in how many patients do I need, to show an effect, or who is the implementation voice? You have trial managers, you have your quality people, you have your statisticians, PI, clinician. Who is the implementation voice around the table?
So if we're thinking about process evaluations, you've already designed your trial, done all the stats and everything else. The trial is about to run, always running. And if we think about this almost like a swap idea, so it's something parallel that sits alongside something else that's sort of going on. What I'm arguing is that in that sort of situation, the sort of PI, the researcher, might be helpfully informed by implementation frameworks in how he designs or she designs their process evaluation. Okay, that's, I think, quite simple to sort of see it in that sort of context. If you want to take it then one step further, if there's if this is something that's worth taking forward, then we might want to think about how we put together the design of a trial at a feasibility sort of stage. So we kind of collect the kind of variables. We do all the usual sort of kind of data sort of collection, but is there something else pertinent to that particular context which an implementation framework might sort of flag up as being important, which would be worthwhile actually either factoring in, or at a statistical level, or one that we at least keep an eye on at a process evaluation level, if you sort of mean. So it depends on how you really want to utilise them. But for me, the easiest method is sort of process evaluation, theoretically informed process evaluation. I think implementation frameworks are helpful for that. I was talking to someone a bit earlier on, some of the other theoretical models that we have, like COM-B model, etc., behaviour change kind of models, don't account for context or organisational structure very well. So on the COM-B model, you've got that wheel, and it talks about that, but does it actually properly elucidate that in a way which actually is useful? I don't find it that useful. So you're back to kind of like individual behaviour motivations, which I'm certainly interventions that I've seen in complex organisational structures. That's probably the least of your worries. It's the big incentives, it's the structures, it's the politics, it's the dynamics in the environment which actually has a bigger part to play than simply an individual behaviour motivation or opportunity. So I would argue that it has a part to play in that, and that could be done quite easily. I think depending on the bit of work that we do, I think it could helpfully inform how, at the trial development sort of stage, how we might design this to be. But I sort of say I'm not talking about everything we do in trials is wrong and we need to do this. What I'm sort of saying, this might be helpful in just our thinking process. Like I find theoretical models helpful in when I'm doing sort of qualitative interviews, for example. Might be informed by a particular perspective. I'm not limited by that framework. That's the other trap. But it's helpful to be informed.
And have we a sense of, you talk of multiple frameworks, one working better than others, or is each individual to a specific context?
Well, these are very much sort of thoughts at this sort of stage. I do, the argument about the importance of context is becoming stronger and stronger and stronger. Everyone is, people are very much sort of talking about this because of the research race. So what I'm arguing is that this might be something, or asking the question, is this something that could be helpful? So I've gone slightly off your question.
And so is there one framework that's better than the other, or is it dependent on the context, or how does one?
Well, what's interesting about those kind of areas that I talked about came from those 7 common implementation sort of frameworks. And I could sort of see several elements in there, which I could think as a trialist might be quite helpful to think about when I'm putting together the design of a sort of trial. So, but that bit of work's not being done. So for me, we need to sort of pull those together and then speak with trialists and implementation sort of scientists, get an understanding of what might be the most popular domains, and then try it. Hopefully that was at least thought stimulating and thought provoking.
Thank you very much.
Pleasure.
Paul has given me a copy of his slides, so rather than pestering him, I'm sure we're all interested in the references. Maybe you can email me, and I'd be happy to pass on the slides to you. It has also been recorded, and maybe send out a link with no visuals, but we have sound. So I can send on that link as well. So thanks very much.
Pleasure. Hopefully that was. Yeah.